everybody to this final episode of the Power Hour series. I'm very privileged to have Dr. Antoinette Cotton. She's one of our local GPs in Swindon, and she's also a near peer fellow. And this is the last of 5 episodes of the Power Hour series. And I hope that you've been able to watch the previous episodes online. And this next few minutes, we'll be talking about communicating in primary care and communication skills. We'll also touch upon a little bit about the SCA exam and some consultation models as well. So without wasting any more time, I'm just going to hand over to Dr. Antoinette Cotton.
Hello, everyone, and thank you for joining us on Power Hour today. As Isaac has kindly introduced me, I'm a salaried GP working on the outskirts of Swindon at Ridgeway Family Practice, and I'm also the Swindon Near Peer and IMG Support Fellow for the GP training scheme. And today I'm just going to be giving a brief talk, just touching through the basics and building on communication skills and, just really building our confidence in communicating in primary care. So why does it matter? I just wanted to highlight that it's not just the fluffy stuff that sometimes when we start training with so many other aspects of it, passing AKT, CSA, having our portfolio, that it seems like communication skills can just be put right at the bottom of the list. And I just wanted to highlight that even within the RCGP curriculum, it talks about the GP consultation, and it talks about developing that capacity of building a rapport of skills to facilitate in the patient's narrative. Okay, so that's all about using those core micro skills, communication skills, to learn about the patient's journey and the patient's history there. And there is a change with a lot of you starting or having hospital posts. You move from in hospitals much more sort of doctor focused in that sense to a much more patient centered focus within a GP primary care setting. And also it allows the patient to do more of the work and also allow them to communicate their ideas, their worries, their concerns, and what they're hoping to get out of the consultation. So, communication and communication skills aligns with the RCGP curriculum in terms of it offers person-centered care. We try to focus on shared decision-making in primary care, in terms of managing uncertainty together with the patient and being honest about that, and maybe sometimes doing a watch and wait approach, or just seeing how things go. And that's all part of also communicating in terms of communicating risks to the patients, etc. And then also doing some reflective learning, reflecting on how our communication skills have worked in positively and negatively, what we could have done better, etc.
And one of the things that one of the reasons why we've chosen this topic, Antoinette, I think, is because this can be quite different to other healthcare systems around the world. And we talk about sometimes we talk about a paternalistic kind of a consultation approach in other cultures, but over here it's very much shared management, like you said. And when I started in the NHS, this is one area that I had to conquer, so to speak, and to understand and have a shift of my mind in terms of how we approach patients and how communication is done over here, which is why I think this is a relevant topic for our international doctors.
Yes, thank you for that, Isaac. And absolutely, I think particularly within the UK and within primary care within the UK, as Isaac said, we are very much focused on a shared decision making, a patient-centered approach in terms of our consultation. And this is quite different to other healthcare systems across the world in terms of even from the patient's expectation. Now the patient expects to be asked about their ideas, their concerns, their expectations, to be involved in the management plan quite significantly. So that's what we're trying to sort of, start off with explaining it and trying to give you a few hints and tips about. Because really, as it says here, the GP consultation is a relationship first. We have the privilege in primary care of being able to follow up our patients, to see our patients on a regular basis, for you to get to know them, and vice versa. And it's building the basis of that already in the consultation. And in terms of gathering that information, it is easier if you have that good rapport, if you have their arsenal in your back pocket, which we'll talk about, of gaining this information. In a sense, also to help with your consultation skills and even your management plan, and because you actually know what is at the core of A, the patient's concerns, and also B, you might pick up on, the patient might mention some things that are very relevant to the history because they feel comfortable talking to you, or you've created that environment where they can express those concerns. So I've mentioned a little bit about sort of the micro skills toolkit, and hopefully this is something that during your training you will come across again. And it's something that even as qualified GPs, Isaac and I, you are constantly trying to improve yourself, and you're constantly trying to think about different ways. And it's important even to self-reflect about, oh, did that work, or maybe that didn't quite work. And some skills will work better in some patients than others. So there's sort of 4 points to micro skills that I was going to take us through. These are sort of keeping it flowing, the power of pausing, soft commands, and also sort of checking and validating. So I'm just going to take you through a few of what these actually mean in a bit more depth. So keep it flowing. You want them to feel like that they are, the conversation is flowing. So it's not a start, stop, question, answer approach, more of a conversation. So, doing both verbal and non-verbal cues are also important, which of course sort of the nudge, making signs that go on, sure. Those things that you are showing that you're actively listening and actively engaging in what the patient is saying to you. Again, with that, you can have something called mirroring. Mirroring is when you're trying with the volume and pace as appropriately, but you try to match that with the patient. So if the patient is a bit more subdued or of a quieter tone, you can try and match that similarly, and maybe to make them feel a bit more comfortable in that. And then ones that actually I personally have found have worked really well for me, and particularly well with sort of mental health cases, is when you just repeat the sort of the main meaningful phrase of the patient's sentence. So as I used there in the example, the patient says, "I just feel so overwhelmed." You as a doctor can just say "overwhelmed" with a sort of questioning approach there. That allows them, or those are sort of cues that the patient is giving you, key points to expand on what they mean by overwhelmed, without you even having to ask, "What do you mean by overwhelmed?" And that actually helps the conversation flow on. Then we've also got the power of pausing, and throughout your training, and even within your SCA, they talk about the golden minute. And that's allowing, even when you're stressed on the timings, both in the exam and also in real life, it's really important to try hold that minute. And a minute actually is quite a long time when you're being quiet, but that minute is a golden minute because it allows the patient to get the main sort of presenting complaint out, as well as also most times, if you remain silent enough, their concerns or what they were hoping for. And that really helps you to build a rapport right at the start, and B, know where you're heading with the consultation in that. And so just give them that space. It's so, if you time a minute, it's so tempting to jump in at maybe, when you think it's been stretching and you look at the time and it's only half a minute that's gone on. So do just practice that sort of waiting with an approachable sort of posture and maintaining eye contact with the patient. And then there's something about sort of soft commands, of steering someone gently. And this is, again, all part and parcel of it. We want to avoid an absolute interrogation. As we said before, this is sort of a joint decision-making consultation is what we practice in primary care. So you want to give the patient an opportunity to tell you and talk to you about it more. As the example I've used there in saying, oh, how come you stopped your medications? You could just be saying, tell me what happened about your medications. An open question, something that allows them to actually maybe even admit that, oh, doctor, I just have been not compliant with my medication. I think the phrasing helps as well for a patient to be honest with that. If you do a phrase of why did you stop your medication, the patient already knows that they might be in the hot seat and they haven't done the right thing, and they might not therefore not be explicit with you or honest with what the actual reason is there. Another thing that you're using about gentle steering is a little bit similar to when we say about echoing or mirroring, where you use a statement as a question. So if a patient has used a phrase, you can, it's almost in essence, send it back to them. So saying, you've mentioned the word failure a few times, and then just leave it open and leave the patient to fill in that space. Because if you do hold back just that little bit, the patient will fill the space with what entirely they're meaning in that sense. And then the last point within the sort of micro skills toolkit is this about validation and safety. You know, and these has 2 points to it. You will hear again throughout your training about summarizing, which is also a great point for during your SCA and also during normal consultation, especially when you've had maybe a complex consultation or a patient who rambles a bit or goes off one avenue and you want to come bring them back, and it helps you and the patient focus. It also is a great example that you've been listening to your patient, because when you list off the symptoms that they've been complaining of and also using maybe their own wording for that, the patient clearly understands that you have, you know, noted all that they're saying. So, you know, that's really important about summarizing. Another aspect of sort of validation is using this my friend Jane, sort of normalizing a situation, particularly when you're talking maybe about a sensitive topic that someone might feel embarrassed about or feel like that it's difficult to mention. For example, in some cultures or some women who might be struggling with mood post having a baby, so some sort of postpartum depression or something like that, might feel like they don't have, embarrassed or not so open to say these things. But if you use terminology like, oh, lots of patients worry about this, or I see lots of women who have problems with their mood post-pregnancy, is that the case for you? Making it simple, making it not such a big thing, also allows that sort of engagement with the patient, normalizing of a situation, and a good sort of rapport and communication between you two.
I sometimes use this my friend John or my friend James technique with especially trying to bring out concerns about cancer. And I say, you know what, you said you've got abdominal pain and you look quite worried. Some people with similar symptoms with abdominal pain or with blood in their stools, they usually worry about things like bowel cancer. Is that something that's crossed your mind? And that's when people suddenly open up and they're happy to talk about it. So I use that technique with that as well.
Yeah. And even I think even it's not just even if you think about it with younger patients, I sometimes use it with younger patients to talk about whether they're sexually active or any chance of any sexually transmitted infections. You know, as a way to allow that to say, oh, I've seen other people, it's not just you, this is a normalizing situation. Okay, so I'm just very briefly, because this is more about communication skills, but this is just to bring you some awareness of different consultation models. And there's lots of information about all these different consultation models online, and I'm sure during your training you will come across these. I'm going to leave Isaac in a moment to talk about Flanagan's consultation model, which is commonly used in sort of CSA practice and in that exam setting. There are also other different consultation models that are used in primary care. And some of those who are doing the AKT might come across these questions there. So it's important to just have a look at them and learn about what the different consultation models are. But unfortunately, in this Power Hour, we won't have time to cover them, except really talking about Flanagan's consultation model.
Thanks, Antoinette. If I can ask you to just mute your mic just to avoid the echo, just for a few minutes, and I'll give, if you have a comment, I'll go back and forth. So as Antoinette was just saying, have a look at all the different types of consultation models. You can find them online, and then you can have a quick kind of summary page of all these models, mainly from an AKT point of view as well, just because they might ask you what more model this is, what model that is. Just talking about this particular model, and I really like this model because this was designed for the CSS, what the exam used to be called before, but it's absolutely applicable to the SCA as well. And the CSA Flanagan's model is what I use when I was giving my exams. And it kind of takes the best out of all the different models and kind of captures different aspects of it. And I've tried to highlight a few of the things that I'm sure you already know and have already done in your past clinical practice. So it covers 10 points, very straightforward. First one, obvious to everybody, welcome the patient. The second one starts with a very open question. So that could be, how could I help you today? Or how are you doing? Or what can I help you with? So just with a very open question. So those two are quite straightforward. The third one is the golden minute. This is what sometimes I find some junior doctors struggle with, especially F1s and F2s, and I kind of try to make them aware about this, is to let the patient speak and use those micro skills that Antoinette just talked about. Use those nudging, echoing, reflecting, my friend, all these techniques you can use in the golden minute to let the patient speak. And if you are really good at listening in the first few minutes of your consultation, in real life, you'll almost get the diagnosis from the patient's mouth in that first minute. So that first minute is absolutely crucial and important, and that's why it's called the golden minute. It says use Google Factor, and I don't know if people have used that before. I use it quite often. So many patients nowadays have access to Google and now to ChatGPT as well, and they will look up their symptoms and they will see what could be the worst possible scenario for my symptoms. And I don't discourage Google, the use of Google for my patients particularly, because there is a lot of good information, especially if they're going through NHS websites. There is a lot of good information out there. But obviously, we have to make sure that the patient knows where to look for information. So I asked my patient saying, well, I wonder if people with such similar symptoms would sometimes put their symptoms into ChatGPT or Google. Has anything come up online? And then patients do tell us, oh yeah, I know what, I'm actually worried about this particular rare disease or so on and so forth. So use the first few minutes to get all the information out. And while you're understanding the golden minute, that's when the ICE of the patient comes out. And I'm sure you already know what ICE is, but we'll talk a bit about that a bit later as well. And then once you got all that out, and we talk about getting out the eyes of the patient, that's the ideas, concerns, expectations, early in the consultation. Because sometimes we leave it till the end, you almost sometimes miss the point of the consultation because you are going through an entire bowel cancer route, for example, and then at the end of the consultation, well, I was worried about vitamin deficiency when you ask for the eyes at the end. So it's good to get the eyes early so that you know where to take the consultation, which road are you going down. And then once you got your eyes out, then you ask focus questions. So again, I'm going to keep using the example of bowel cancer. So if it's bowel cancer, you're asking about black stools, weight loss, loss of weight, night sweats, all of those things. Right? So you're asking focus questions, and then you can use something called aggregated lists. All right. So this is something again new that I learned when I was preparing for my RCA, because when I was doing the exam. And that is when you use a few questions together. So we often tell our trainees saying, don't double barrel questions. Don't say, well, do you have nausea, vomiting, abdominal pain? Don't use many questions, and the patient won't know what to answer. They'll forget what they've been asked as well. That is one thing that's true, and we still say that. But it's sometimes good to use something called aggregated list. Again, I'm going to use the example of bowel cancer. So I would say something like this. So I'd say, right, so you're concerned that you've come with symptoms of abdominal pain that's been there for 4 weeks, and you're concerned about bowel cancer. Here are the symptoms what we would typically associate with bowel cancer. Symptoms like black stools, blood in the stools, swelling around the tummy, swellings around the anus, weight loss, loss of appetite. Those are the symptoms we would say would point towards bowel cancer. Have you had any of these? And then you kind of have given the patient a nice, neat list of symptoms for them to think about as a checklist. And then they'll end up saying, well, I don't have any of these, or they might say yes to one or two of those. And then you can say, all right, well, just remember these are the symptoms of bowel cancer. So when you leave from here, look out for those symptoms. So you're already doing part of the management in the history itself. So I really started using aggregated lists, but you do it very tactfully, very skillfully. Obviously, you can't give the 10 symptoms. You can only give them 4 or 5 symptoms at max. But you're kind of packaging these symptoms into neat packets. Then you say, I'm going to ask you a few symptoms that will point towards infection. Do you have any fever, any nausea, any vomiting? Have you traveled any recently? And then they can have so you package those symptoms. You've aggregated those symptoms into one list. So that's one of my new favorite things that I've started to use. You have to be skillful about it. It comes with practice, but that's again something that Flanagan's model tells me about. On to the next slide. Number 6, we already talked about this summarizing. So you summarize everything that you've collected. This is where you kind of cross the bridge. You're about to cross the bridge. You're thinking of how you've collected everything on this side of the bridge, because you don't want to come back after crossing the bridge. You kind of pause. You ask, is there anything else I've missed? And you're almost drawing a line in terms of the exam. You're drawing a line saying, all right, I'm going from collecting the information to management. So this is a very key step in the exam. We would say normally minute 6 or 7 is where you want to be there, because you need to leave enough time for examination and then management. Then step 7 obviously is the management is examination, where you examine the patient. Step 8 again, explain what you're thinking, give them options, and it says option sharing with a spin. So again, this is again something I learned from my first clinical supervisor. He said, when you are presenting patients with options, think of it like you're at a gift shop, and the patient is a customer, and you have a few gifts in front of you, and you want the patient to take this gift. And let's say, for example, the gift over here is doing a fit test. We're talking about cancer again, fit test and review. Patient is keen for this gift on the left over here, which is a colonoscopy and a scan and referral to the hospital. And the third gift over here is just a watch and wait. But you want them to take the middle gift. So you kind of put all 3 gifts on the table, but you make this middle gift nice and beautiful. And these are the words he used. He used gift wrapping, and I remember this very clearly because he wrote it on a post-it and stuck it on my computer saying, gift wrap everything that you're doing. And when you gift wrap that particular this thing, you say, well, you know what? I don't think we want to watch and wait, because I don't think that's the safest thing to do. Because I agree there's something happening and we need to look into it. So you're saying, that gift is bad over there. Don't take the wait and watch. And then you say, but I don't think we need to jump to do colonoscopy and a scan and refer to the hospital right now, because and that's definitely on the table, and we might need to do that in the future. But I think the next best, simplest, non-invasive, using all this flowery gift wrapping language, next best, the most logical next step, or the safest best step, is this option. What do you think? And so you put the 3 gifts, you made this one look pretty, and then the patient says, all right, doctor, I think I'll go with what you're saying. But and you tell me, you know what, that colonoscopy is on the table, we won't take it off yet. And then you make a shared decision at point 9, you make shared decision making management plan, and then close and summarize safety net, and then that's your exam case done. So try and practice this Flanagan CSA model with when you're doing your consultation skills mocks, or you're practicing with a friend, or in real life situations as well. See if this works for you. Antoinette.
Perfect. Thank you so much, Isaac, for that. And that was a really good summary of the Flanagan's model there. And I think hopefully you can see how we married in the micro skills toolkits that we were using throughout the consultation in terms of shared decision making, about gaining ideas, concerns, and expectations, about keeping the consultation flowing. Now, I came across this and this sort of consultation, and it's much longer than the time that we have to play it. So I think I'll only play about 2-3 minutes, which I think will be enough anyway for this Power Hour series. But I do encourage you to watch the whole thing, and you can maybe watch it with another colleague and think about things that weren't okay, and then things that weren't so good, and what she could have used and how she could have changed up the consultation. So I'm just going to play this for the next 2-3 minutes, and then we can discuss a few things about it. Too long, okay. All right, I thought I would stop it there. And then, it's a great consultation to watch in your own time. So I'd encourage you to watch the rest of it there. So, I mean, we could talk at length, couldn't we, about multiple things in terms of the discussion there. And I think Isaac and I will just mention a few points about that. Now, I mean, if I can take you back to those micro skills and toolkit that we've talked about, you know, just to talk briefly about it, but there was, you know, failure to nudge or any echoing. So, the doctor cuts her off with, okay, let's see your record. Another thing, another example, different phrasing that she could have possibly used in that scenario would be, tell me more about your feelings of feeling overburdened. She used that word before. And to allow a more open approach, allow the patient to express that. Now, with the echoing, the patient said dropped many cues, even in the first 2 minutes of us watching that, about that she's feeling anxious, that her husband works away a lot, that she's doing an online course. Lots of different things where you can just say anxious, as we talked about, repeat her phrasing anxious, and then say, tell me more. Just simple phrases like that will open a whole host of information that the patient can give you. Again, sort of the failure of soft commands. So there was I hope you noticed, a rapid fire checklist that the doctor wanted to get through. Sleeping okay, eating okay, work okay. Already you're already putting answers in the patient's mouth and saying work okay, question mark, instead of how is work, how are you eating, allowing the patient to have that ability to respond. So you could use the phrase, for example, of, could you expand on what your sleep pattern is like right now? As you could see just before we stopped it, the patient was mentioning about her sleep, that the doctor had already said, there'd been a bit of animosity between, that's why you're not looking after yourself, as just a sweeping phrase, which obviously you could see the patient's reaction was not a positive one in that sense. Another thing that you could have was sort of a failure of feedback or validation, sort of, as I've mentioned, ignoring emotional cues. The patient is basically asking you, she is anxious, she's seeming overburdened, overwhelmed. Sometimes when we talk about in different consultations, they say naming the elephant in the room, speaking out what you observe. You sound quite tearful when you talk about feeling unmotivated. Is that the worst part of it? Some sort of phrasing like that, where you acknowledge the patient's feelings. So also they can also see that you have acknowledged it and you have witnessed, the stresses that they're going through, for example. Isaac, I don't know if there was anything else you wanted to add in regards to that.
No, I think it's so important to actually put yourself in the patient's shoes and just think about how you would address that person if they were somebody who was close to you, and that's essentially the core of good consultation, where you empathize with the patient. I know you might have had a string of bad patients all morning, but then for each patient, you have to have a new, fresh perspective and new, fresh empathy to offer them. And once you have empathy, then most of your consultation will go smoothly.
Yeah, and so I think just in terms of this power hour, in terms of takeaways and challenges, excuse me, Isaac has already mentioned about trying the Flanagan's model in your consultation and gone through that. Thank you, with great detail. So trying that would also be great. You don't have to get all the points in one, but trying to have that sort of structure and is a great way. And then trying in using the Flanagan model to try embed these micro skills. Even just try pick one that you try that day, for example, or that week, and say, this week I'm going to try echoing and see how that works for me. Or that this week I'm going to try having what we call the golden minute, or the dynamic silence in the beginning of the consultation, just seeing how much I can get from what the patient says, and therefore gleaning their ideas, concerns, and expectations. And then, I mean, all of this is a learning process. It's learning how you're trying to merge these micro skills and the Flanagan model's consultation skills into what works best for you as a doctor, with still having this sort of basic structure in place. So yeah, I just wanted to say thank you for listening in. I hope you found it useful, and just keep communicating because it really is at the heart of all we do as the GP in primary care. Thank you so much.
Thank you so much, Angela. Thank you so much again, everybody who's watching this online. I hope this has been useful. I think this is such a neat snapshot into what you need to know for consultation in primary care. I think we've covered quite a lot of ground in these 45 minutes, and I think it's really neat that we could touch upon most of the important things you need to know for the exam. So thanks again, Alkina. Thanks again for those of you who stuck through our Power Hour series. All the best in your career. All the best in the future. Take care. Bye-bye.
Thank you. Merry Christmas.
Merry Christmas.